This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1200, recorded on March 13th, 2025. I'm Vincent Racaniello. You're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
1,200 or 1,200, I don't know, but...
It's a big number. It's a big number, Vincent.
Yeah, we're going to keep going, right, Daniel?
We are, despite efforts to stop us, which maybe I'll mention a little, but start off with our quotations. Effective communication is 20% what you know and 80% how you feel about what you know.
Does it mean you have to be confident in what you're saying?
You know, I was just in I was in Malaysia. So I started off in the northern part of Borneo, and then I was in Western Malaysia, and then I'm up in Bangkok, and I'm at the Asian Vaccine and Antiviral Summit, and the chair of the session that I spoke at was this guy, Tiki, who, it was funny, he was actually the professor of like half the people in the session. So, and he had a couple of these quotations that he put up there. And I'm a sucker for good quotes. I'm not sure what to make of this, but I thought maybe this was similar to a quote by Maya Angelou. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And so there's an emotional aspect to being a human being, and I think that's maybe that's part of communication too. Is if you can get people engaged and excited, then maybe there's some content that gets brought across.
I think so. I think that's fair, but you do have to have content.
You got to have the content, and that's what I worry about. I mean, I have met some just passionate teachers, and the problem is the content.
Speaking of content, what's on your tie, Daniel?
So this is a viral particle. It's supposed to be HIV. I have a lot of these that are like artist versions of HIV. I don't know if there's anything particular about it that makes one think of HIV, but
I think many of them are wrong.
Yes, actually.
But as some artist said to me once, we're artists. We can do what we want.
Well, I have to say, even some of the life cycles in parasitic disease that are textbook, I always feel like, Sid Dixon, they're not exactly. He's like, I know artists. So, but all right, so we've got a lot to talk about this week. So I really looking at the Ebola situation, I did not get much new information from the WHO or Uganda. So kind of see what happens there. We left it off with a identified second cluster, the boy that died, the mother, the sibling that died. So when I have more, I'll share it.
By the way, Daniel, you haven't mentioned this second mystery disease in DRC, right?
So we don't really know what it is, and that's sort of there always are these mystery diseases, and it is tough, and particularly it always tends to be the DRC, right? I mean, the DRC is an area where very hard to get information, and and it was described as people getting sick, and within 48 hours, people dying. They ruled out the usual suspects, right? So the filoviruses, Marburg, Ebola, hemorrhagic fever stuff. A lot of people have malaria. What exactly else is going on? I don't know.
Supposedly started when a couple of kids ate a bat.
Yeah, but that's funny. They do that. They do that.
Yeah, I know. So I'm not sure. And now there's a second cluster further away of 400 cases apparently, and again ruled out. But the last mystery one in December was a mixture of malaria and respiratory disease, right?
Yeah. So I'm not sure what, but I jokingly, but honestly, people eat bats, and these are not these little bats that you might be used to in the U.S. and Europe. Mm-hmm. These are these big flying foxes, and they're about the size of my small dog, about the size of a Cocker Spaniel, right? And so it's a lot of meat there.
Got it.
So and sometimes you're really hungry. So I've never eaten bat, so I actually don't know how it tastes, but
that's kind of like chicken.
Okay. Have you eaten bat, Vincent? I hope
No, I never ate a bat. No, okay. I don't get very exotic. No.
All right. So just a little update on polio, and more. I bring this up because I'm always curious why they make this distinction between the wild and the vaccine derived. But just the polioeradication.org, you can go there and you get like a weekly update. Polio this week. It's like this week in polio. Not to be confused with this week in parasitism. Pakistan, we've got 18 wild polio virus 1 positive environmental samples. And then they talk about the rest of them really vaccine derived. And so 3 cases in Chad and 3 positive environmental samples. And these are cases, kids getting paralyzed. DRC, a case of paralytic polio, vaccine derived. Nigeria, 3 cases. The occupied Palestinian territory, we've got 3 positive environmental samples. Boy, where did those come from? Tanzania, we've got 2 positive environmental samples. And all of these, except for Pakistan, these are vaccine derived polio that we're basically putting in the environment.
Shows how hard it is to eradicate polio virus. You can't do it with the current strategy. And the type 1 in Pakistan is a problem with vaccination, I think. It's hard to get to certain populations, and that might solve it. But there's a lot of polio out there in the world still.
Yeah. So, a reminder why it's important to continue to vaccinate, because I know certain people don't actually believe in germ theory. They don't think that you get polio from a viral infection, but you do. You do. The polio virus will actually make you paralyzed. So.
That was debunked like the 1800s, right? This miasma theory.
It was for most people. It was the late 1800s when it became really clear, right? I mean, we talked about with measles, that person injecting blood from one person to another. That was not like no wet hair, no poor nutrition there. That was basically getting exposed to the pathogen.
And Robert Koch in Germany shows that bacteria cause disease, and then later viruses cause disease. So that's it. No, it's not. It's a contagious entity, not air or whatever.
Yeah.
And we're going backwards when people mention miasma again. The only thing that's the miasma is there's a miasma of anti-think going on.
There is a miasma of anti-think. So, all right. And with that, let's move right into measles. And we are seeing outbreaks all over the place. I think I was listening to one of the Paul Offit's Beyond the Noise recently, where he was predicting that we're going to see outbreaks of measles all over the place. Paul, they're here. So we're seeing cases Alaska, California, Florida, Georgia, Kentucky, Maryland, Jersey, New Mexico, New York, Oklahoma, Pennsylvania, Rhode Island, lots in Texas. We'll talk about that. Washington. So let's go through a little bit. So we get updates from Texas every Tuesday and Thursday. As of Tuesday, they said 223, but we're hearing it's already over 250 right there in Texas. We had the 1 pediatric death in Texas. New Mexico, as of Tuesday, 33 cases, and we had the 1 adult death. And now those are just sort of give you, why do you get these other, say, oh, it's been over a decade since someone died of measles in the U.S. That was an adult about 10 years ago. It's been 2 decades since a child died. That's the other number you get on there. And the measles outbreak down there in Texas, New Mexico, was actually spread to Oklahoma, and a couple of cases up there in Oklahoma. We heard about those on Tuesday. And right here, very close to home, Vincent, measles case confirmed on Long Island. And this is unvaccinated child under the age of 5, lives not far from me. He actually went to Cohen's Children's Hospital, this crowded children's hospital where my daughter, Daisy's hoping to get a job as a nurse, if you're listening. She's going to be applying soon. She just passed her nursing exam, or NCLEX. And so this child went there, was in the ER, as my understanding, was also up on one of the wards. And, it's one of those tough things. If you don't think about measles, you may not make the diagnosis. So I'm going to, little refresher, we'll talk about like what should make you think about it. California, LA County Department of Public Health has been notified of the first case of measles diagnosed in an LA County resident that recently traveled through Los Angeles International Airport. Ouch. Second case over there in Pennsylvania. And for maybe a map of what's going on, maybe David can have this up for our YouTube viewers. So we've got a map here where you can see all the areas where we're having measles outbreaks across the U.S., a country that once what we were declared like measles free, but we're
Yeah, measles elimination. Yep.
yeah, not so much anymore. And then they just to give people a sense of what's going on. How did this end up in Oklahoma? And you could see that in this map that you've got a clustering. Most of the cases down there in Gaines, which is New Mexico has kind of that southeastern border. Right there is where you meet Texas. But then Texas comes up, a bunch of cases in Dallam, which is right up by Oklahoma, and as mentioned, a couple of cases up there in Oklahoma. So.
Yeah, Daniel, I think there's a failure of public health. We have a lot of reasons why people are getting infected, many unvaccinated. But in the end, I think we failed to get them vaccinated. And that's really, unfortunately, in this administration, I'm not sure we can improve that. But I think that's what needs to be done.
Yeah, I'm going to try to be bipartisan in the statement and say this didn't just happen in the last 2 months, right?
Right.
This growing anti-vaccine, this is growing mistrust of vaccines. It's been going on for a long time, right? It's been going on for decades now. And particularly in some of these communities, when you get, when you start thinking, oh, it's a religious exemption, it actually isn't. It's a trust issue. They don't necessarily trust. There hasn't been good communication, and there's been a lot of miscommunication. We'll talk a little bit about that. And it's not just the U.S., right? So Canada, statement from the chief public health officer of Canada. Because Canada is still a separate country, by the way, on the increase in measles cases and risk to people in Canada. In Canada, we have more cases reported in the first 2 months of 2025 of this year than we had in all of 2024. So as of March 6th, Canada had recorded 227 measles cases. Right?
Daniel, if the measles spreads from Canada to the U.S., are they going to put a tariff on it?
200%. So, and one of the things I thought was interesting, and it sort of comes up here in this Canada, I'll leave a link into what's going on in Canada, but they bring up this issue that so we've talked about normally the vaccine schedule is you wait until 12 months of age to start. So 12 to 16 months or so, 12 to 15 months, you get your first dose. Maybe that should be pretty close to 12 months. And you get your second dose, 4 to 6 years of age. But if you're going to be in an area where there's high risk, there's this recommendation that at 6 months of age, that infant gets an extra dose, right, to cover them for a period of time. And so, this came up recently. An oncologist, I won't mention their political persuasion, but they're saying, there's a lot of travel back and forth to Texas. Like, well, what was the recommendation? I say, listen, if the infant is going to be in an area where there's measles, and boy, we live right here in Long Island, that's becoming an issue here. They're studying this and starting to talk about, maybe that extra dose at 6 months to protect, because that was the issue in New York City where we had a child under 1 got measles during that window when they weren't protected. So.
Well, the 12 months is picked because you get less interference with maternal antibodies, right?
Yep.
So 6 months is iffy, but, I don't know if it will help.
Yeah, it is interesting. It's a recommendation with not a lot of data. And so there's actually some ongoing trials right now looking at, the 6 months. So,
well, on TWiV last year, we did a paper where they addressed this issue, and they concluded that 12 months is the best trade-off between interference with maternal antibodies and risking getting infected. So that's why we do that.
Interesting. I wonder about the concept, like we do with RSV, like what if you give mom a dose, right before she gets pregnant, you're thinking about getting pregnant, get a boost, have those high antibodies, maybe that'll give you, protection during that 12-month window.
It makes sense because back in the day when there was a lot of measles, everybody got measles in the 50s, right?
Mm-hmm.
And then mothers protected their babies with maternal antibodies, but that's not the case anymore.
Yeah. I mean, that's an interesting argument that someone makes. They're basically saying, well, the reason measles is a problem in the U.S. is because of vaccines. And that back before vaccines, when moms all got it.
No. It doesn't work that way. So many kids died and had encephalitis and other problems. Definitely. No. It's not worth it. We have to figure out how to deal with it. But I do think that a vaccine for pregnant mothers would be not a bad idea.
Yeah. I mean, you need to do it if you're going to do an active. We don't recommend that the current vaccine during pregnancy, right?
Right.
It's a
Right.
replication, so it's recommended before or if no sign of immunity after. But yeah, that whole idea that like this is the fault of vaccines, it doesn't make any sense. Most of these moms would have gotten it when they were young kids, and the idea that they have this high level and it makes no sense.
There used to be an inactivated vaccine in the 60s.
Yeah, and so that was the issue, right? I think I had that, inactivated, means equals ineffective. Like that was the
It
problem.
wasn't
It was
very good.
just
Yeah.
not very good. Yeah. Also, measles is a huge problem in Europe, right? I mean, it's sort of the birthplace of the anti-vax movement. And you could just see some areas there with really just number of measles cases in January alone. And you've got areas in Eastern Europe where it's greater than 100. Most of Europe, you have between 11 and 100 cases. This is just January, just in that 1 month. So you can see Spain, France, Germany, Ireland. I don't know. I think the UK is just not giving us data. That's probably what's going on.
The dark green one, is that Ukraine?
No, so Ukraine is a little bit above that. I got to get my map out.
I thought Ukraine had water access, right?
So it does, and it's the area northeast of the dark green area there. So
because there's a lot of measles in Ukraine.
Let's go to
because of the disruptions, they haven't been able to vaccinate.
And actually, not only that, right? But as we know, there was this massive effort to undermine confidence. So let's see. So you've got Moldova and Romania. So Moldova is that small country, and then Ukraine is so the dark area is Romania.
Yeah.
And then you've got the small country of Moldova, and then Ukraine is northeast. So
above
Ukraine,
it. Okay.
Goes.
So Romania has a lot of measles.
Lots. They had over 100 cases just in January. So yeah, a lot of cases there. And also we're having, some advice from the European CDC about, please get vaccinated. So just reminder for clinicians who might be seeing this, patients who might be seeing it, parents who might be seeing this. Remember the 4 Ds, the 3 Cs, and the 2 Vs of measles. Have you ever heard of this before, Vincent?
I've never heard of this, no.
Okay. So it might take...
Is this immunology or something?
Well, okay. So it might take 10 to 14 days after exposure before you start getting any symptoms, right? So, and I'm going to leave in a link to a YouTube video from Children's Hospital of Philadelphia. It's got our buddy Paul Offit, and he's there with one of his colleagues. But here's the deal: so 4-day fever, that's the 4 Ds. Cough, coryza, and conjunctivitis. That's the 3 Cs, right? So cough, we know what that is. Coryza's not only just runny nose, but really a lot of inflammation of the nose. And then conjunctivitis, and this is that really significant conjunctivitis. Then comes the rash, right? And so that's the problem. You get the 4 Ds, the 3 Cs, then you get the rash. So in the first 4 days or so, you got a kid who's fussy, he's coughing, runny nose, his eyes are irritated, he's got a fever. That could be anything. And they're way contagious. And then comes the rash. And the rash starts usually with a few blotches on the face, behind the ears. Then it spreads to cover much of the body, joining together into these large patches. The only trick I will say, who is the one with measles? Well, they are the sickest kid in the room. These kids tend to be miserable. And the measles virus is one of those viruses that make you sick, right? Your tagline there. What are the 2 Vs? The 2 Vs are the 2 vaccine doses to avoid all this misery. All right, so 4 Ds, 3 Cs, and the 2 Vs. Now, there was a nice editorial, I thought, short, sweet facts and myths about measles published in the Lancet Infectious Diseases, a repeat of some of what we discussed previously or recently. So measles is probably the most infectious pathogen out there. 90% of people without immunity will become infected after exposure. Not just infected, right? Because we're not doing PCRs. These are people who actually show symptoms. The virus is airborne, and this is real airborne. This is lingering in the room for 2 hours. This is someone walks through the waiting room at your pediatric practice, and next thing you know, everyone's got measles. The other, as I pointed out, is that people are infectious before that characteristic rash. And then measles is bad. Measles causes pneumonia in 1 in 20 cases, right? So you get 10 to 20% of kids end up in the hospital. You get inflammation of the brain, that's 1 per 1,000. The fatality rate is 1 to 3 per 1,000. Then you get that horrible broad immune amnesia, right? So you're gonna wipe out up to 70% of your pre-existing antibody repertoire. It's going to infect your memory B cells, your memory T cells. Yeah, so bad stuff. But we have a vaccine, Vincent, a highly effective vaccine. 93% protection after one dose, 97% after a second. But, let's be honest, there are some side effects, right? So some kids, and it's estimated 1 per 3 to 4,000 vaccinated kids will get a fever high enough that it'll trigger a seizure. So we see that. Self-limited does not lead to epilepsy. 1 in 40,000 will end up with a drop in the number of platelets, so immune thrombocytopenic purpur. There actually have been reported 3 cases of inclusion body encephalitis after vaccination ever in the entire world.
So, what are these numbers for infection? Does infection cause febrile seizures?
So yes, I mean, and that's the whole thing, that the vaccine is always safer when you look at all these, right? So we're talking about 10 to 20% of the kids ending up in the hospital. We're talking about fevers with, febrile seizures, which are very common. 1 to 3 deaths per 1,000. I want to say the MMR vaccine there's no deaths after MMR vaccine, no attributable deaths from the MMR vaccine. Nobody has been killed by the MMR vaccine. Nobody gets autism. That's not the thing. Actually, I have to say the next question from that physician asking me questions about the vaccination of the granddaughter was, they're still using that vaccine that causes autism, are they? And I said, oh my gosh. So the MMR vaccine, it doesn't cause autism. That was an unscrupulous guy who committed fraud, who thought, like, if I tell this story, I can make some money. Started lying, lies to this day, makes a ton of money off people by telling that lie. There was another concern that, the MMR vaccine, it's got mercury in it. Mercury's been out of the vaccine for a long, long time. And actually, by the way, in Europe, they took it out way before us. And autism rates have actually increased after the mercury. The thimerosal was taken out. So maybe we need to put it back. I'm also going to leave an article from 2015 called "Deaths from Vaccination." What does the evidence show? Right? Because you want to actually have something to cite here. And so, and going through, right? So polio vaccine, your vaccine, Vincent. There once was a 3-month-old infant that died from myocarditis after oral polio vaccine, but this was a prior one that's no longer licensed. And in that case, the polio virus from the vaccine was actually isolated in the child's myocardium. There have been 2 published case reports of immune compromised children who received the chickenpox vaccine and was felt to potentially be contributing to their death. But as we point out, you're not supposed to give replication competent attenuated vaccines to immunocompromised people. But there have been no concerning patterns suggesting a causal relationship with MMR vaccine and any deaths ever. Okay. So why would certain individuals spread lies about measles? Why would they do that? And so there's this editorial. I'll leave a link to this editorial that we're talking about in The Lancet. The editorial points out alternative treatments such as herbal medicines, homeopathy, supplements, and others are not evidence-based, but alternative and complementary medicine is big business. One report estimated a market size, you ready for this market size? The US alone, $144.68 billion. That was 2023. So we're talking about over $100 billion industry driven by this misinformation. There's also just large profits just in this whole anti-vaccine movement where you get people just to give you money. And so one estimate has put the revenue from the social media platforms for the anti-vaccine content at $1 billion per year. So they're earning a lot of money. Now, RFK Jr. himself was chairman of the Children's Health Defense, this not-for-profit that focused on, quote unquote, eliminating toxic exposures, focused on vaccines, including launching lawsuits against vaccine developers. And that organization back in 2023 had revenue of $23.5 million. And they paid RFK Jr. a salary of $20,000 a week. This is in addition to all the other money he makes. So they were paying him a salary of $1 million a year for spreading all this junk.
You know, what's ironic, Daniel, is that, RFK Jr. says no vaccine has ever been properly placebo tested, yet none of these alternative treatments have been tested in any way. What a conflict statement there, right?
It's really kind of crazy. Yeah. Vaccines are bad, but all our other weird stuff that we're going to tell you to put in your body, we don't even know what's in these things. It's fought so hard to keep them from being regulated. Like, if they're going to sell you, echinacea, you're like, hey, is there really echinacea in there? You're not allowed to check.
The person who's going to be Surgeon General, she has her own alternative things that she puts together herself and sells. It's crazy.
Yeah. It is crazy. Yeah. No, it's interesting because I'm, the same Paul Offit thing where they've got a cut from Elizabeth Warren where she's saying, RFK Jr., you're making like all this money off, suing Big Pharma. I'm not saying you have to stop suing Big Pharma. You sue Big Pharma all you want, but you have to stop taking the money. I'm not going to stop suing Big Pharma. And then later he's like, I'm not going to stop taking the money. And then he's like, well, I'm going to take the money, but I'm giving it to my son. So,
Right.
So, well, I'm going to leave a link into an Atlantic article. His daughter was America's first measles death in a decade. And I'm not going to talk too much about the article. I'll sort of, recommend people read it. It's a really nice article by Tom Bartlett, photos by Jake Dawkins. But I think if anything, it points out that this isn't really necessarily a religious issue. It's a trust issue. And, I think we have to actually be honest and say we've fallen down. We science community, we in the medical community have not done a great job of communicating, of creating that trust. So I just want to bring that up. But it's a really, really good one, just pointing that out. All right, bird flu. You ready for bird flu?
Yeah, let's do it.
Okay. So I'm going to start with a survey shared on Eureka Alert. Less than half of parents think they have accurate information about bird flu. So it's good that we're covering it because we're going to talk about this. So where are parents trying to get the information? So they're trying to get them from news reports, right? People still, read the news, they watch the news. This is followed by social media and online searches. Family or friends, government agencies, healthcare providers were less important sources. Isn't that kind of crazy?
They should all get their information from TWiV Clinical Update.
The people need to get it more. Do we count as news reports? I don't know. Maybe
I think we're social media, right?
We're social media. Okay. So we need more people can come and listen. But I've got a nice, was it like it's almost like a graphical abstract with a, parents' confidence that state, federal government's ability to handle bird flu. So, you have a small group of people that are very confident. Most people are not confident or only somewhat confident. Removing infected animals or animal supplies from the food supply, not seeing a lot of very confident there. Informing people which products should be recalled or thrown out. Small number are very confident that's happened. And then not a lot of people are very confident that this won't spread to humans. Well, it is spreading to humans, by the way. So kind of right on there. So I'm going to talk about an MMWR, and then we're going to give some advice. So MMWR, human cases of highly pathogenic avian influenza, H5N1, California, September through December 2024. And we read that during September 30th through December 24th, 2024, a total of 38 persons received a positive test result for highly pathogenic avian H5N1 viruses in California. 37 were dairy farm workers with occupational exposure to sick cows, so makes sense. One person aged less than 18, undetermined exposure. We don't know how that happened. This was the first pediatric patient detected with influenza A H5 in the U.S. So, the 37 occupational exposure to sick cows. The one, we don't know how they got it. They did sequencing of 30 of the 38 infected patients, and all were that H5N1 clade 2344B, B for bovine, right?
Mhm.
A substitution associated with reduced baloxavir, Xofluza susceptibility, was identified in one virus sequence from a human case in California.
Hmm. That's just random
Yeah.
because it's hardly used, as you say.
Yeah. So where did that come from? It's just completely random. So no additional concerning substitutions were identified, right? So you could always use Tamiflu, oseltamivir. Now, there was an absence of cases among household contacts, consistent with the absence of viral genetic markers for efficient human-to-human transmission. So folks are getting it directly from birds, they're getting it directly from the cattle, in this, the dairy cows, actually, in this
Hmm.
case. But we're not seeing human-to-human transmission. So what's the current advice? Some of this stuff is like, I remember growing up with this advice, Daniel, stop playing with dead birds.
Stop
It was
playing with
just,
cows.
don't play with sick cows. How about that? Don't play with sick cows. So, yeah, right now, right? So the people that got it from playing with the sick cows, quote unquote, I mean, they're actually there doing their jobs. So far, no one has been particularly sick from that. So this bovine clade B attenuated exposure. A few isolated cases of direct from the ducks, right? The clade D ones, where people have been quite ill. But it's still at this point. What do you tell your kids? Yeah, wash your hands. Don't play with dead animals. But in general, we'll keep watching this. It is concerning. We have probably over 1,000 herds here in the U.S. We have all the spread through the chickens, through the hens. Any thoughts, Vincent?
The poultry industry is the one where we have to watch out, right? Because they get killed by it,
Yeah,
and that's a big problem. They have to cull. That's why there's an egg shortage because they had to cull so many laying herds, right?
yeah.
So I mean, I'm less worried about people. I'm worried about the animals,
Yeah, and the
and
food security, right, that comes with that.
yeah, and there have also been infections of mammals in the wild, like sea lions off South America. A lot of them died.
Yeah,
So
big deaths. Yeah,
so die-offs are a problem, and I worry about that. And I don't know what to do about it because you can't immunize all those. And birds flying and infecting other animals, there's not much you can do about that.
yeah. It's a challenge, right? Because a lot of the migrating, particularly the ducks, they don't get sick, so they're migrating. They're spreading this. They're yeah. So. All right, so that's bird flu. We'll keep up on it. Keep informing you as best we can. All right, let's move into this is testing. This is like generic testing before we get into any specific diseases. So this is trends in respiratory pathogen testing at U.S. Children's Hospitals, published in JAMA Network Open. An invited commentary: changes in respiratory viral testing before and after the COVID-19 pandemic. And basically, they looked at over 5 million encounters where children or adolescents had a viral presentation, mostly to emergency departments, some getting admitted. And about a third of the time, there was some viral testing going on. But you really saw over time an increase. So pre-pandemic, you go back, it was only about 13-14% of the time that they did any specific testing. They just said, oh, it's probably a virus, good luck. They probably treated them inappropriate with antibiotics, but we won't mention that. But then as the pandemic went along, they started testing. And it peaked at 62%. I'm actually kind of surprised, right? Kids are sick enough to end up in the emergency department or the hospital. They've got a viral presentation, and you're not going to test to see if it's COVID or flu or what exactly it is? Okay. At some point, it was COVID only. Later on, you had all these, small and large panels. But there was a cost issue too, right? So, when you do just these, focus tests, it might be $34. When you start doing these panel, large panel testing greater than 5 targets, you actually get up to cost about $128 per test. And a lot of these panels include SARS-CoV-2, so COVID-19, influenza A, influenza B, respiratory syncytial viruses, human metapneumoviruses, etc. So it's really interesting because the commentary was kind of bemoaning that we were doing all these testing and hearkening to the days when we could just say to the parents, It's just a virus. So they conclude their commentary with the sentence, it may likely take years to return to a time when families are comfortable being told their child has just a virus without the need to know which.
What do you think, Daniel? If your child has respiratory symptoms, they be tested for COVID and flu? Because you're not going to treat them, I presume, right?
Well, it depends actually, right? So if they're in the emergency department, sick enough to be in the emergency department or
Hmm.
potentially get admitted to the hospital, I would, yeah, if it's flu, I would want to treat them, right?
Okay.
We're up to 100 pediatric deaths for flu already this year,
Hmm.
right? It was 98 when I last checked. So, and remember, half of those kids are otherwise completely healthy, right? So, a bit of a disaster. We do know that if you treat these kids with oseltamivir or baloxavir, Zofluza, you can actually reduce their chance of dying. You can
Hmm.
also, reduce their chance of having problems. So, yeah, I would want to do that.
What
Um,
What about COVID?
so there, it would be like a risk issue, right? So we have had over 1,000 children die from COVID. If the child has risk factors, then you want to look at treatment. So it'd be
Mm.
good to know. RSV, I think of more as an exposure issue, right? Because we don't have any specific treatments for RSV.
Yeah.
But if your child is RSV, and grandpa's got a birthday on Saturday, you may be like, sorry, grandpa, Johnny's got RSV.
Sure. Sure.
He's just got a virus. Well, then when, grandpa, ends up getting RSV, we lose about 20,000 older folks. The other thing is that I don't think people knew what a problem RSV was in elderly people till we started testing. We were taught in medical school, oh, it's a pediatric problem.
Yeah.
But
Yep.
now we realize, you knock off, 20,000 older adults every winter, you can really make a difference. So if you're doing this testing and people are aware, like, oh, what is RSV? This might be an educational opportunity where they can get Beyfortus, nirsevimab, might be an opportunity to talk about vaccination. I actually, and it also might be an opportunity to not use unnecessary antibiotics and mess up the microbiome. So I'm hoping we don't return to a time when families are comfortable being told that their child just
Yeah.
has a virus.
Do you think would be worthwhile to have an RSV antiviral?
I do actually, right? Because we have about 300 children die a year from
Hmm.
RSV, 20,000 adults, and that's the immediate, right? And you and I have talked a little bit about this. That's when you look at just deaths from RSV, in that first 1 to 2 weeks. But I was at a talk recently where they were showing data on the significant increase in heart attacks and strokes in the following few months. And I certainly
Hmm.
don't want to have a stroke. So I just, for some of us, that's like a fate worth, I'd rather just die and, hopefully I get reincarnated, hopefully as one of my dogs. But, I just, there's a lot of things, the risk of dementia in the next several years goes up markedly after an RSV infection. So,
Hmm.
yeah, I would love if there was an antiviral and start figuring
Yeah.
out if we could impact not only the acute deaths, but also some of the sequelae.
So I'm going to have a dog in this frame on TWiV, huh?
I've got one dog over there that he got such a short haircut that I think he looks like a goat.
Poor guy.
Poor Pippin, but he's very happy. All right. And just along the same lines, free COVID-19 test program stops taking orders as of Tuesday. So, the US government used to provide those free at-home COVID-19 tests, no longer accepting orders. And we don't know whether the program will ever restart. This might be the end of that. Okay, flu is still high, but we're starting to see a little green, starting to see a little light. There's a few areas where the flu activity is starting to come down. So we're really starting to go in the right direction with flu. I've got kind of this trend of emergency visits in the U.S., and you can see influenza really pretty significant peak, significantly more than we had, back in 2023, for instance, when we had a fairly bad season. So we had that double peak, and now we're on our way down. Um, RSV, sort of similar things. We're still at high levels, but we're starting to come down. But more good news on nirsevimab, right? That's that passive vaccine, that monoclonal antibodies for kids. Estimated effectiveness of nirsevimab against respiratory syncytial virus, published in JAMA Network Open Pediatrics. Test negative case control study with 680 RSV test positive cases, 2,410 RSV test negative controls. The effectiveness was 68.4%, against infection. Look at that.
Hmm.
80.2% against RSV-associated hospitalization, 84.6% against severe RSV disease. And then you see this kind of peak and decline. So they're saying the RSV infection was declined 79% when you look at 2 weeks. Post-immunization drops down to 54.8 at 14 weeks. So these are actually, I guess you'd say, symptomatic infections, right? Because they showed up as a case.
Mhm.
So not just screening by PCR. Okay. COVID is at the medium level, and in most states, the mortality due to COVID is down in that less than 2%, with just a few exceptions, Wisconsin and Virginia. And there comes the wastewater. It's on its way down. So I'm feeling pretty good about where we're headed there. I also, not only can we look at what's happened the last 6 months, but maybe David can have this up for folks on YouTube. We're still seeing this biannual peak, right? We're seeing a summer and a winter, a summer and a winter. So sort of gradually going down over time. So
Never gets into the very low level, you notice?
yeah, it never gets very low, right?
No, only low.
Yeah. So. All right, are you ready? I have a new section this week called Origins. So cue the hate mail. Yeah. So let us get going with a little bit of controversy, shall we? And the Nature News article, What Sparked the COVID Pandemic? Mounting evidence points to raccoon dogs. So more than 5 years on, studies suggest the animal is the most likely culprit, but other candidates haven't been ruled out. And this was published by Smriti Malapati. And we read, today, mounting evidence from more than a dozen studies points to a person or people catching the virus from a wild animal or animals at the Hunan seafood market in Wuhan, China. And the animal at the top of the list is the raccoon dog. I've got a nice picture. Maybe we'll be having that up on YouTube. The origin of the pandemic is still deeply politicized. I don't know if you were aware of that. And the lack of clear answers hasn't helped. The virus probably originated in bats living in southern China. From there, many scientists think it infected an intermediate animal that passed it to people. The virus could also have passed directly from bats, although this is considered less likely given their habitat is far from Wuhan. Nice review and a really cute picture of a raccoon dog.
Yeah, they're so cute. Why would you want to eat them?
They must be really tasty.
Still.
Yeah, he's so cute. I mean, really, he looks like your puppy. Why would you want to eat your puppy? Yeah, so. But this sort of makes me, he's so cute, and now I'm worried that people are going to be like, let's wipe out all the raccoon dogs because they may have caused the virus. I'm going to start promoting the lab leak because I'd rather they wipe out the scientists than the cute little raccoon dogs. Which
No. There's no evidence for a lab leak, as you know.
Yeah, but look how cute he is. Look at those eyes. Come on. Remember, it's about emotion.
Yeah, 80% of emotion. That's right.
Yeah, don't let the facts stand in the way of a good theory. All right. SARS-CoV-2 variants. We see, I can put on the glasses for the fine print here, XEC is losing out to LP.8.1. All right.
So what's the significance of this? Anything?
Who knows? I guess when they pick the vaccines, and maybe we'll talk about that later, there's this whole idea that, maybe you want to be as close as possible just to get the best antibody response. I'm not sure.
I think this administration is not going to bother making new COVID vaccines, and we're going to do an experiment. Let's see if the old ones work for the next 5 years.
And that might not be the worst experiment. So.
Well, it could be mean to some people, but
yeah,
it would. I mean, I personally think that the first 3 vaccines are good enough as long as you want to take Paxlovid, right?
It's interesting, right? So the first 3 vaccines probably give you that 90% reduction in developing severe disease, right?
Yeah.
But particularly for high-risk individuals who so let's say you went from like a 20% chance of ending up in the hospital, now it's down at 2%. But your booster can reduce that chance by another 50% for the next 6 months or so. So if you're 2% down to 1%, so. But yeah, we have to be realistic about we're not able to offer quite as much benefit with the boosters as that initial series, gave us. But we have a new vaccine on the horizon, the made at McMaster inhaled COVID-19
Oh,
vaccine.
that's Canada.
Really? Canada?
They're gonna put a tariff on it, Daniel.
That's the problem. So there's this AeroVax study supported by $8 million in funding from the Canadian Institute of Health Research. And they're going to test, they say, needle-free vaccines. So we read findings from preclinical studies and the soon-to-be published data from the phase 1 trial indicate that McMaster's inhaled vaccine is more effective at inducing immune responses than traditional injected vaccines are because it directly targets the lungs and upper airways where the virus first enters the body.
Wait, Daniel, an inhaled vaccine goes into the lungs?
Yeah. This is sounds like a marketing thing, right? We should be standing in front of the White House in a Tesla when we talk about this, right? I want to see the data, like soon to be published data. Like, show me the data. But they're moving ahead, and so they're gonna get 350 participants from across Canada, Hamilton, Ottawa, Halifax. I'm gonna leave in a link if you want to enroll. So if you're one of our Canadian listeners, they can still listen for free up in Canada, right? You're not gonna start charging the
Yeah,
Canadian.
but you bet. Always free.
You betcha. Okay, so this is actually a booster, if we could use that terminology. You need to already have those 3 doses of an mRNA vaccine. They don't want you ever to have gotten an AstraZeneca. I don't know what the story is with that. They say have not had COVID-19 infection or vaccination within 3 months, right? So you want to make sure there's a period of time. No underlying lung disease, and then be available to come to these visits and be aged 18 to 65. So we'll leave in some info there. All right. And not a lot here changing as far as treatment for early phase COVID, right? Number 1, Paxlovid. Number 2, remdesivir. If you can't get those, molnupiravir is the redheaded stepchild. Convalescent plasma is the redheaded nephew, I guess, step nephew or something. I don't know. COVID early inflammatory phase. Steroids, anticoagulation, pulmonary support, remdesivir, immune modulation. I didn't include, but there was an interesting study on proning, right? Where you have people lay belly down. We were doing that a lot of times when people were on ventilators. And there was actually a recent study where it was people not on ventilators, just having them basically sleep on their bellies. And there was a mortality benefit. So people with severe COVID, not severe enough to require intubation. So I've been practicing belly sleeping, just in case. So
I go to sleep on my belly, and I wake up in the middle of the night. I'm on my back.
Okay. Yeah, I've got some bad shoulder issues from multiple injuries, so I'm just never comfortable. All right, COVID, long COVID. So here's kind of a hot topic. What about early antiviral treatment and long COVID? So mixed results, and I want to point out not an FDA indication, but we do have the article, Risk of Post-Acute Sequelae of COVID-19 and Oral Antivirals in Adults Aged Over 60, a nationwide retrospective cohort study published in the International Journal of Infectious Diseases. So these are the results of a retrospective cohort study that used data from the Korea Disease Control and Prevention Agency and the Health Insurance Review and Assessment Service. They analyzed data from COVID-19 patients aged 60 and over from January to December 2022. Primary outcome was the occurrence of 27 post-acute sequelae of COVID within 30 to 120 days after COVID-19 diagnosis. So what did they find? So nirmatrelvir, ritonavir, Paxlovid, significantly reduced the risk of cardiovascular diseases, including heart failure and cardiomyopathies by 14%. Cardiac dysrhythmias reduced by 17%. Ischemic stroke reduced by 12%. It also lowered the risk of hospitalization due to respiratory diseases, including COPD, about 8% reduction. Reduced kidney disorders, including folks ending up on dialysis, 43% reduction. Acute renal failure reduced by 15%. Now, molnupiravir, some stuff there, also reduced risk of ischemic stroke by 16%. Cerebral vascular diseases, 16%, respiratory conditions down 13 to 14%. So basically, Paxlovid, nirmatrelvir, ritonavir significantly reduced the risk of cardiovascular diseases. Oral antivirals lowered the risk of hospitalization, which we knew. molnupiravir reduced ischemic stroke and cerebrovascular disease. Respiratory conditions, COPD, asthma decreased by approximately 13 to 14%. All right. And I will wrap it up as we've been saying for over 5 years now. No one is safe until everyone is safe. I'm just about to head down to Floating Doctors to see how they're doing down there. I'm going to be heading down Saturday. So maybe when people are listening to this, I'll be down in Panama. So I want people to go to parasiteswithoutborders.com, click on the donate button, because for the months of February, March, and April, we will double your donations up to a maximum donation of $20,000 to help Floating Doctors continue to do the great work they do down there in the archipelago.
Watch out for those mosquitoes, Daniel.
I will.
Time for your questions for Daniel. You can send yours to daniel@microbe.tv. Helene writes, I'm a 68-year-old healthy female, had my last COVID Pfizer vaccine September 2024. I am leaving on a river cruise around Holland and Belgium on April 21st. I would like to get a vaccine a few weeks ahead. Not sure whether I should get Novavax or Pfizer. Which would give better immunity? Has either been updated since September?
Okay. Yeah. So there's some interesting stuff in here. So, what Vince and I talked about before, where, the original 3 are going to give you that 90% reduction, but a boost can give you, it's a 33 to 45% or so reduction in ending up, in the ER, medically attended COVID for, this period of 6 months that they had looked at. So Novavax and Pfizer, there was a little bit of a difference, right? So the initial recommendation was make a JN1 vaccine, which Novavax went ahead and did. And then they said, oh, wait, JN1 has this new KP2 lineage, sort of in the JN1 family. If you can do that. And so Pfizer and Moderna in at least the US and some parts of the world, but not all, did create this KP2 updated vaccine, as I like to call it. They don't want to call it a booster. And so we really actually, so far, I haven't seen any compelling data that change really made a difference. There isn't a huge difference between the JN1 original and the JN1 lineage KP2. There have been no updates since September. If you look at the data for Novavax, I think it's comparable to the mRNA vaccines, so Pfizer and Moderna. The question would be, how well have you tolerated? If you got your COVID vaccine, your Pfizer vaccine in September, tolerating them well, reasonable to continue with something that's working for you so far. It's often easier to get the Pfizer vaccine, to be completely honest. So I think either would be fine. And as we mentioned, you're above 65, so the current CDC recommendations, while they're still making them, would be to do a shot every 6 months to get that extra little benefit.
Michelle writes, I was born in 1959. My internist tested my antibodies for measles and rubella. Measles was positive with an IgG value of 4.6. Rubella was negative with an IgG value of 0.6. I had mumps as a child. For someone like me who seems to have measles and mumps immunity, would you recommend an MMR booster?
Yeah, so measles, mumps, rubella, right? So what we're seeing here is you looks like you had measles, right? So 59, that makes sense. You probably had an infection, and this is a survivor's immunity for the measles. You had mumps, so you got that there. So what you're really kind of dealing with here is the rubella. So you don't necessarily have rubella protection. You're born in 59, so that's going to put you in your 60s, I guess. So yeah, what would we usually do in a situation where you're still sort of vulnerable to rubella? The rubella vaccine only is part of that MMR. So I wouldn't actually recommend an MMR booster. It would be the series, right? So you get an MMR shot, and then the recommendation for catch up in adults is to wait at least 4 weeks to get that second shot, and then you'd be fine. So that would be the general recommendation in this kind of a situation. But yes, I see discussing with your internist. So I would recommend go ahead and have that discussion.
John writes, I see long COVID patients here in New York City. I have 2 questions. One, some of my patients request off-label treatments with drugs that are being studied, for example, Truvada, low-dose rapamycin, Maraviroc. I've held off on this because there's some risks, and to be honest, I don't think there's a good biological rationale, but case could be made on either side. Where do you come down on this conundrum?
Yes, let me start with the first part of your question here, John. So this is a tough area where and I think this is it probably evolved over time. So early on when people were having long COVID, there really was nothing out there. We had no idea what was going to work. Some of these people were incredibly desperate, and there'd be a discussion about risk benefits of trying things. I never was comfortable with Moraviroc or low dose rapamycin. I just could never understand like why it would make any sense. So in general, I have that discussion. Like there are certain things, and I put these in that long COVID review, where we actually have some degree of evidence. If you're interested in trying these other things, really the idea is to get into a trial to figure out. Because you don't want to end up having a side effect and have an issue, and you never know. Like, did this person get better or not get better? So in general, I'm hesitant to use things that don't make any biological sense where there's potential risks.
Second question. I've seen several patients with persistent COVID pneumonia, all of whom were on rituximab or another B cell depleting drug. One had infiltrates for a year and was treated with steroids for organizing pneumonia. Interestingly, they present as chronic low-grade pneumonia with cough, fever, shortness of breath, but without classic long COVID symptoms, despite having a viral, quote, reservoir, unquote. All of them improved rapidly on Paxlovid, have not recurred. There are many cases reported of this, and sometimes there is apparent recurrence after a standard length course of antiviral. I'm curious about your experience with such cases, how long you would treat with Paxlovid, and whether there might be a role for IVIG or convalescent plasma.
Yeah, so John, there actually have been a number of case reports where they've followed people specifically like this. So this is a unique patient population, the basic B cell depleted individuals, people with certain hematological malignancies, and they actually go ahead and it's nice where they follow like rising RNA copy numbers, go ahead and treat them. Sometimes they've treated them with combination therapy, so course of remdesivir, course of Paxlovid, maybe out to 10 days. So there are unique situations like this where not just this isn't your run of the mill, take 5 days of Paxlovid during that viral replication first week. These are people who have an immunological problem. And so, yeah, there's been a number of case studies out there where they've actually approached these Paxlovid, remdesivir, even in some cases, this they call hyperimmune plasma at this point, where basically people have been vaccinated, and then that plasma is given. So there are a number of case reports out there of that approach.
Jessica writes, I recently heard there's a listeria outbreak in U.S. nursing homes that has some associated mortality. Is this true?
Yeah, this is true, and it's a bit of a shame. So, a lot of times in the nursing homes, they'll have these supplemental shakes, and I think this went out as a health alert. And these frozen supplemental shakes were contaminated with listeria. So, like a dozen people died, and dozens of
Mm.
people ended up requiring hospitalization. So, yep.
And finally, Ellen writes, I'm 77, old but healthy. My niece is coming to visit on several long flights. She says she just had COVID. Does she need to mask in airports and on planes?
Yeah, so we talked about the fact that there still are multiple variants out there. I mean, in general, when someone gets COVID, it's very, it's very unlikely that they're going to get COVID again in the next 3 months. It's not unheard of. So you're 77, that's not great. We talk about the fact that forget about, medical problems. The biggest risk factor for a bad outcome with COVID is actually age. It starts at quadruples when you're above 50. When you get above, 75, it's really up about tenfold. So, she needs to think about that. On long flights, particularly if you're sitting there crowded with all those people, I'll throw a mask on. It's not just about me; it's also about having it and potentially spreading it to someone that I care about. Apparently, she cares about you enough that she's headed all the way to New Mexico on several long flights.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Thank you, and everyone be safe.